Please introduce yourself, your postdoc.
Morning, respected faculty and dear colleagues. I'm Dr. Wasim Rashid, an international fellow at Severance Cardiovascular Hospital, and today morning I'm going to present the EGM conference. So the patient was a 55-year-old male, diabetic with diabetic nephropathy. He had a history of aborted sudden cardiac arrest in 2020 and was subsequently implanted an ICD in an outside hospital the same year. He was implanted with a biotronic ICD with a DX lead with floating atrial dipole. But the subsequent course has been that of recurrent ICD shocks and syncope. And it has been continuing since 2020. So his time course of clinical course has been quite eventful. After the ICD implantation, he had multiple ICD shocks for which an initial LV mapping and ablation attempt was done in 2020 in an outside hospital. Before the ablation, he underwent evaluation with coronary angiography, which was normal, and MRI was attempted but was limited by ICD artifact. The records revealed that the ablation attempt had failed, but further records why it had failed were not available. Then in 2021, his ICD was tried to be reprogrammed and evaluated, and he underwent a non-invasive VT study with the ICD. And a sustained VT was inducible at 290 milliseconds, and DFT was also checked at that time, and it was 10 June. In 2021, he underwent RF catheter ablation and the likely targeting the anterior interoceptal region. But he continued with recurrent ICD shocks, and optimization of ICD programming with ATP was done in 2022 because VT was successfully terminated by ATP. In 2022, again in December, he had a slow VT and the programming zones were changed. In 2023, because of ongoing ICD shocks, he underwent cardiac sympathectomy. And in 2023, the records mentioned that 2 more ablation procedures were done, and the notes from these ablation procedures mentioned Purkinje or scar-related VT substrate modification at basal septum and summit region. In 2023, he underwent stereotactic body radiation for refractory VTVF, but he had post SBRT VF recurrence, and the 2 episodes were likely PVC triggered. Finally, in 2024, he again underwent ILAM-guided VT ablation, and after that, he remained asymptomatic for about 6 months or so. For 2025, he was mostly asymptomatic, but in 2024, at 26 April, he again had a slow VT, and the slow VT zone was reprogrammed. Now, this time he presented with syncope with recurrent arrhythmia symptoms, but because of past so much of eventful history, he declined admission. This was his ECG in 2021. I will show you the ECGs, which how the ECGs progressed over the years. This was in 2021. This was in 2022. By 2024, his ECG revealed significant conduction system disease with PR prolongation, RBBB, LAHB, and this was his pre-procedure when we took him again for ablation. His baseline X-ray revealed an ICD in place and basal atelectasis in the left lingular lobe. This has been there from 2024, and a CT was done which revealed a left upper lobe lingular segment collapse. But he did not have any respiratory symptoms because of this, and it has been there from 2024. Now, coming to the ICD interrogation, when we saw his device tracings, we could see episodes like these where PVC is triggering where a PVC is triggering a short VT, which quickly degenerates into a polymorphic VT and VF. And the episode continues, and despite shocks, the episode is continuing. The VF is maintained. And further shock, no termination. Again, VF is maintained. And finally, the VF gets terminated by a shock, and there's post-shock pacing. Echocardiography revealed enlarged LV with end-diastolic diameter of 64 and reduced LV systolic function with an EF of 43%. RARV was normal in size and function. There he had some elevated LV filling pressures. Sinus of Valsalva and ascending aorta were moderately dilated. He had eccentric left ventricular hypertrophy and minimal pericardial effusion. Before taking him up for the fourth time ablation, the pain ESD score was evaluated, and he had a low score, except for if we give 5 for VT storm and diabetic status 3, he had a score of 8. So he was taken for a quadri redo ablation. This was the catcher position. We started with a CS in place, and we gained a transeptal access as well as an arterial access for retrograde approach. These were the baseline EGMs, and I want to highlight that the HV was prolonged at baseline at around 95 milliseconds. While catheter positioning, he underwent spontaneous, induced slow VT was induced spontaneously, and this is the 12 lead ECG of that VT. And these are the EGMs. These are the EGMs of the VT. There's clear AV dissociation, and this is the VT. Now, while the VT was going on, we mapped with HD grid, and this is the propagation map of the VT. So in this propagation map, we see that there are no the clear-cut slow conduction zones, except for one in the septum and one near the LV outlet. The one at the LV outlet is more slow, while as one at the septum is not really, does not look to be of much interest. So this area was of interest. These are the activation maps and voltage maps. The voltage maps reveal that there is not much scarring of the LV endocardium, though some areas have low voltage. The activation maps revealed isochronal crowding near the same place as in the propagation map. There were areas of delayed activation in the LV, and these have been shown in these EGMs, which were picked up by the HD grid. The VT was got terminated, and we again tried to do a mapping during RV pacing, but it was unremarkable. Then we tried to do pacing, this mapping during LV pacing via the coronary sinus branch, and this is the propagation map of LV pacing during LV pacing. It revealed the same kind of slow conduction zone near the LV outlet, and this corresponded to the map during slow VT.
Is this the LV pacing?
Yes.
Looks like RP.
This is LV base. And we got similar. So we tried to ablate at this zone, but it was very close to his, and we tried to give some burns in the LV outflow tract as safely as we could away from the his. But we were not satisfied, and we tried an retrograde approach through the LCC-NCC junction. We took an aortogram and positioned our catheter as close to the tagged regions as possible. And these were the kind of EGMs at ablation site. So, but after doing this much of ablation, we tried to induce again, and we were able to induce a VF, which looked pretty much similar to his clinical VF from stored ICD EGMs. Again, it's initiated by a VPC, and the VF is maintained. And we had to shock the patient to, it was sustained imminently unstable, and we had to shock the patient. So the question is, what do we do next? We don't have much endocardial scarring or this target areas or substrates on endocardium, and we have one target area at the LV outlet, which we tried to ablate as safely as we could, but he still has maintained his inducible VF, and which matches to his ICD stored electrogram. So what next strategy we can do to decrease the risk of sustained VF in this patient? So here I want to refer you to this article, Prevention of Ventricular Fibrillation through Denetworking of Purkinje System. This was published in 2019 by a German group. And they showed that this was the proof of concept paper on Purkinje network substrate modification for prevention of VF episodes. The rationale was that this concept builds on 3 decades of Purkinje arrhythmia biology. Early observations found that verapamil sensitive arrhythmias implicated the his Purkinje system in initiation, but subsequent case series showed that catheter ablation of PVC arising from the Purkinje network shortly after MI could suppress electrical storm, and with the degeneration of Purkinje fibers in infarct portal zones hypothesized at the arrhythmogenic driver. So until this time, Purkinje network was implicated as an initiation trigger or an arrhythmogenic driver near infarct portal zones, but now the paradigm has shifted from trigger-only ablation towards the idea that Purkinje network itself is a modifiable arrhythmogenic substrate. Hence, systemic substrate ablation of Purkinje system rather than trigger-only ablation may benefit patients with recurrent VF lacking an overt substrate or trigger. And the strategy in this ablation is to map the conduction system, the fascicles, the trunk, and try to ablate the smaller channels in between, away from the main branches. We imagine a virtual triangle with the base at the distal most recordable Purkinje potentials and apex at the his, and we try to create a linear line in the middle and at the base. So with this, we tried to map the his Purkinje axis in this patient, and the orange dots are the his dots, and the blue dots are the fascicular dots. So this is with HD grid, we tagged all these areas, the his, the anterior fascicle, and the distal Purkinje potentials. And after ablating, the VT was induced, but it was no longer sustained. We completed the ablation set in this manner, and this was the final ablation set. A vertical line on the septum between the fascicles and a base, as I showed from the proof of concept paper. And this is an illustration from Professor Nogami's paper showing how it is done. And our ablation set mirrors this image quite well. And after completing the ablation, we tried to induce again, but no arrhythmia was inducible. And this was after RF, and this is the post-procedure ECG. So what are the endpoints for this kind of Purkinje network modification, substrate modification? One is it's still a work in progress and evolving, but the proposed endpoints are non-inducibility of VF or polymorphic PT. Second is elimination of all mappable Purkinje-like potentials, and the third is completion of Purkinje muscle junction ablation across all fascicles. Here I want to highlight one case report from Japan where partial modification sparing the distal left fascicle created a monomorphic VT, Purkinje-related VT. So this was the first ablation attempt, but patient still had inducible this. Then they ablated all the distal Purkinje-like potentials and nothing was this. So they suggested that we should aim for complete ablation at the Purkinje muscle junction, and this may be a good endpoint. We acknowledge the contributions of Professor Nogami and Professor Komatsu and their inputs in this case. Thank you.
Question to question. One question. For patient history, lab, and technique. Anything? One question is low VT ablation of low VT is that clinical?
He had episodes of slow VT, and we had to clinically, that was also relevant because we multiple times had to program the monitoring zone. He had episodes of slow VT, which were terminated by ATP. So,
This middle-aged gentleman underwent VT ablation. It was first time, right?
yeah.
First time. And underwent radiation therapy, sympathectomy. We tried to do everything. That's a really terrible, honestly. But the ejection fraction is pretty good, 40%.
49%. Mid.
Yeah, let's go back to the first slide. So if the patient came to the outpatient clinic, he put ICD in another hospital, but the patient came to the outpatient clinic after having the ICD shot and syncope. So what will we do? Let's check. ICD intubation was the appropriate shot. No, we already evaluated this patient is non. And during follow-up, patient came to your outpatient clinic, experienced IC shock and syncope. Injury. And what will it do? Interrogation was appropriate shot. What kind of end was it from? Yellow. What about the oblate? Beat oblate? If it is an appropriate shot. Another complete. What is your choice? I think either way is okay, based on the Procedural and managed to primary vehicle, not primary vehicle ablation, but after getting shot, the initial ablation is already proven methodology by ICT, but generally we try the 90% drug first. If the patient shot under 90% drug, then either we bring the patient to the lab for ablation. That is Vanish 1 criteria. So you need to remember Vanish 1, Vanish 2, and Protita trials. Okay, that's a very important evidence for your practice. But before deciding ablation or antiperspirant drug, you need to check why patients fainted. Here's ICD. So what kind of probability you have the cause of syncope? Number one, shot energy was not enough. Number two, program failure, detection failure. Number three, any other cause of syncope associated with vasovagal syncope. What else? Question? Do you have any other idea? Because in this time of hot summer, the heart failure physicians prescribe heart failure medication, lowering blood pressure. Some patients faint because of hypothermia. Anyway, you need to have the reason for the syncope. If it is an IC programming issue, you know, so we show utilize failed IC shot, so energy was not enough, right?
Only once DFT was checked and it was quite reasonable. But later,
probably at the time there was minimal PT and the tender work. But as Washington shows, the progressive change occurs with the hydromyopathy or how
Cannot hear the voice.
my voice? Really?
Table side.
Oh, okay. So your voice.
Yes.
So progressive ECG change. In other words, this patient's cardiomyopathy is progressive disease. Did anybody check the genetic test for this patient? As far as remember, genetic study negative. Yeah. I checked the VT, middle-aged VT with non-ischemic cardiomyopathy. I checked the genetic study in every single patient. So, what else? What should we do? It was the appropriate ICD shock failed to terminate. That's why the patient fainted. Dr. Zhang, how will you change ICD program?
I mean, in device clinic, I will check the zone, the therapy zone, and monitor zone and therapy 1, 2 zone, and check the event, and I will gonna check the rate of the rhythm so that it can be therapy. So and I will gonna confirm the energy of the shot to professor, and because I mean it was HP, right? Shot. Yeah, shot. Then I'm gonna change the how to manage the rhythm.
How to? That is a question. Increase the energy, initial shock energy, right? So because the based on the DFT, probably first shock was not that high energy. So, but it changed. But the last episode, there was slow VT, 130 beat per minute. So that's why it was outside of VT detection zone and there was no therapy. So at that time, how will you change the program?
Then I mean it was 140, right? So
140,
140. Then I wanna set the monitor zone from 120 to 140, and the next for V fifth zone, 51 zone, 140 to 150.
But if you widening the window of VT detection, what kind of program do you expect?
Then if we get the artifact signal, we can do inappropriate shock. So we should consider how we set the monitor zone.
How?
Then I'm gonna check the in device cleaning. I do kind of patient make many moves so that we can get the any noise or signal. So I wanna do that.
Okay,
Yes.
Dr. Huang, could you please your experience? Could you share your experience? If the patient shows a slow VT, also the VT detection zone, so how will it change it? What kind of adverse events do you expect?
Usually, if the motor zone is widened, the
Please.
longevity of the ICD drop. So I usually think of is it clinically meaningful significance? If it is stable and it's okay, then I just slightly lower the quantity, the VT, it's 125 or 130, but you should think about the patient's age and the usual status. So if the patient's, even though the ejection fraction was slightly relatively okay, 43, so I think he can move and do anything. So just lower slightly the monitoring zone and see what happens. And also I want to check the dose of the antihypnotic drugs and beta blockers.
At that time, he took the Sotolo, right?
Oh.
Actually, his BT, amiodarone worked well to his BT, but there was a little change of thyroid function, so I changed to Sotolo, low dose Sotolo, and it shows the slow BT. And when you reduce the IC detection zone to 130, 120, there's a probable the repeated shock. So if the VT episode is frequent, patient will come to emergency room by repeated shock. So you need to warn the patient before change program. Anyway, this patient was very big guy, almost over 90 kilogram, and very tall guy. And he was initially very, very anxious after having the IC shock. So if the patient got the repeated device, then you have to take care of the psychological issues. Some patient got depression, some patient commit suicide. I saw 3 patients commit suicide after having the repeated device in the shock. Unfortunately, all those are not my patients, but I saw. So every time I encourage him and send the patient to psychiatrist, and now he became too brave. After having shock, he refused to hospitalize. Oh, I'm okay. I'm very familiar. But after several days, he got the IC storm and came to the emergency room again. So that's why we conducted the fourth VT ablation. Okay, let's go to the VT ablation procedure. Can I show the max? You can see the progressive widened QRS progressive. Maybe repetitive ablation widen the parts. Okay. So go back to PANS score. So I strongly recommend the PANS score before the patient VT ablation in patient with cardiomyopathy. If it is over 15, the procedure-related mortality is almost over 20%. It is 30 mortality. So it is very useful score. And also at the beginning of procedure, don't forget to check the baseline pH and lactate level. And ask the nurses regularly check the pH and lactate, especially patients needs repeated VT induction, that the blood pressure diving almost to 60, 40, and even after the eliminating VT, patients will fall to the decompensate heart failure. So pH and lactate. Actually, it is behind the story. The PANS score was initially reported by Santangeli, but after his first the publication, so slowly the general anesthesia factor disappeared in the paper. Afterward, there's no GA. So I asked the Santangeli personally, why you eliminate the GA as one of the parameter of PANS score. So one of reviewer strongly denied GA because his reviewers using GA in every patient VT ablation. So currently, you can eliminate the GA in the PANS score. Okay, let's go. Okay, let's see the path. Can I see the VT morphology? So, can you guess where does it come from?
V1 to V6 is negative. One is positive. AV is positive. And 2, 3 AVF is negative.
It's post-receptive, right? Almost 80 post-receptive. And there, okay, this one, slow beat. At that time, did we see the island? When you present this cardiomyopathy VT ablation, it's better to display the voltage map and the LAT map side by side, and the propagation map separately. You will present it at the APHS, right? No?
This came after. This we did after the submission density.
Oh, okay. Yeah, like this. This is VT, right?
And this is VT, slow VT, activation and voltage.
So, could you please share your experience, Dr. Ong? How do you map the ischemic VT, non-ischemic VT, and this side, the target side?
First, I would like to perform cardiac MRI again, because we can obtain the good cardiac MRI imaging using meta-artifact canceling features nowadays.
Can we use new protocol?
Yeah.
Oh.
So you can obtain the good cardiac MRI imaging in patients with ICD or CRT. So we need to check again cardiac MRI, and also can you show me the ICD in intracardiac electrogram? Yes. Yeah, I think the initiation of the BF might be this one.
Yeah.
Not this one. This PBC, and this is the trigger of the BF. So this QRS looks narrow compared with other ventricular activity, and also more narrower than sinus rhythm QRS. So this might be originated from Purkinje. So I think the trigger is Purkinje PVC. So our target may be Purkinje. And also we need to decide where to ablate from cardiac MRI. We can obtain the information, the trigger substrate from the MRI. So any ATP during the VT?
Device reasons like how it is on the system.
I it worked.
ATP worked previously in
But you can predict them, so the participation ATP worked, right?
yes, previously.
ATP is a kind of event pacing. So you can check the PPL as TCL. So just at the ATP. And
The fact the suspect the re-entrance circuit.
Yeah.
Okay.
And so I wonder this large sky area is poor contact or real.
Likely for
Yeah, I think
Yeah.
it's in the perimeter area.
Yeah. This might be.
So how can you interpret this LA map, approach map, to decide the target?
It's difficult. Probably, yeah. This area may slow conduction zone. However, I'm not sure this area. We need to check signal again. It may artifact or noise. Very
Yes,
very
delay the potential you showed, right?
yes.
Yeah.
Here. Is this that? Is this near field or late activation?
Very sure.
Yeah, that one.
Okay, this one. Then you annotated this point, late potential. And so in this case, I think near field picture also helpful.
So VT map shows that the isochronal late activation, the purple color, and there, of course, there's slow conduction zone around the low voltage area, very spot area. But during RVPC, I didn't see any ILAP. And
No,
yeah,
RVPs.
okay, and LB pacing. So I changed the pacing side to the LB. Point I think both slides looks same.
Brad used
It
this
is not LB pacing.
as RVPs.
Yeah, please check it. Yeah, double check. And then still there's only the peri-aortic area shows the isochron late activation timing. So I eliminated those, the late activation pattern. But it was still, yeah, the orange spots are the T-spot of recording size. So what's next? After induce?
When we went to the from the dusk. So
Yeah. So I don't think you will see now.
after that, it was induced.
Okay, before induction, if there's no significant line of block or island, so what should we do? I conducted the different side pacing, but how do you think about the S2, S3, in mapping?
Yeah, it may be helpful in this patient because the island is not very clear.
Yes.
Yeah, so we need to check S2 map.
But you don't do that in routine nowadays.
That routine is very time
Like your
consuming.
publication.
Yeah.
Okay. So if there is no significant eye level line of block, you can try S2S3 pacing or different pacing, differential point pacing. Then induce again, and no stable monophilic, but the BF. So before this case, if it is BF, we left it because we cannot ablate BF. But at that time, fortunately, that Professor Novami and Dr. Matt was here, and I learned about the D networking from them. Okay, well, please show us our patient plan. Yes, that's the sky blue dots are all Purkinje potential sites like TAC and antivascular, post-vascular until their apical. Okay, and the red spots, if you look at the red spots, there's no Purkinje potential. That is in between antravascular and post-vascular. So Nogami and Thomas asked me, don't ablate the side where it shows the Purkinje in between, because Purkinje network is subendocardial structure connecting to each other. So their target is epicardial Purkinje fiber, not the Purkinje potential showing site itself. And even though they are same group, Dr. Nogami prefer longitudinal ablation, Komatsu transverse ablation. So I start with Dr. Nogami's recommendation, longitudinal ablation. But last time I put a little more about the transverse. So make a cross-shaped ablation, reverse T-shaped ablation. After that, the inducibility was significantly low. And I asked them what is the end point. During ablation, you have to carefully watching the QRS. If there's a little axis change on width change, you should stop. Okay, that's why they're trying to spare the Purkinje potential showing area. So most important point is that is in between Purkinje potential showing posterior vascular and intravascular, not the vascular showing site itself. Okay. And after reinduction, we didn't see inducibility quite low. So I finished case and the patient, I think it was almost one month ago, right?
20th August.
Yeah. So we have to wait longer. This patient has significant cardiomyopathy. Wait and see. Comments? Okay.
The patient is doing well now.
Yeah.
Yes, last follow-up was on 20th August. And
Yeah. Glad to hear that. But if this final, not final, but forced ablation doesn't work either in the future, what should be the next step?
I think if the ejection fraction range would put his name in the transplant.
Yeah. I strongly agree that even though this patient is not in the end stage of heart failure, but if everybody saw his history, so this kind of intractable malignant ventricular arrhythmia should be considered as a heart transplantation recipient candidate.
And the genetic trait is also very important. Recently, public paper. Actually, it was the UPenn BT registry data. For example, LMNA mutation. After BT ablation, BT-free survival is less than 20%. Okay, that's a very malignant disease. And dystrophin, decimal Purkinje is also very bad associated with heart failure. So, whenever I send the patient to the heart failure physician and his name get into the transplant list, they became very depressed. So please, if the physician shows the bright side and encourage the patient, and the heart failure patient, physician will prepare his long term. Yes, please.
Strategy is to identify the interior and posterior fascia, and get a line where you cannot see Purkinje.
Yes,
Just
yes,
linear line.
yeah, linear line. So actually, it was started from the long time ago. It was also from the European groups, cardiac surgical, 7 endocardial resection. In patient with intractable VTBF, they resect subendocardium, eliminate all the his potential, and reduce PT inducibility. And nowadays, we have a strong weapon with high density mat. And you have to read the paper published by Meyerberg. It was very, very historical paper, very old paper. But he suggests why the Purkinje muscle junction contributes to VF maintenance mechanism. There is a diseased Purkinje muscle junction make partial conduction block and slow conduction zone make a micro reentrant circuit. So I have a question to you. Purkinje system is antiarrhythmic structure or proarrhythmic structure? We always trace the Purkinje potential as a target of ablation. How do you think, Dr. Wang?
But function arrhythmia, proarrhythmia.
Proarrhythmic structure.
Depends on
Purkinje.
depends on the situation.
Okay. How do you think? No answer. Your voice.
I refuse to answer.
Uh-huh. Okay, Dr. Yim, how do you think? This newcomer. I think yes, you have idea. you just you are just shy. So actually, in normal heart, Purkinje system is antiarrhythmic structure. Okay, because Purkinje cell has actually longer refractory period than working myocardium, and the conduction velocity is fast. So longer refractory period and the fast conduction velocity lower the risk of reentrant, and the activation spread all of the ventricle. The simultaneously synchronize its antiarrhythmic. Problem is when it's a sick heart, there is a partial conduction block and local conduction disease. Purkinje muscle junction plays a role as a reentrant circuit or the trigger point. So last the TTS JHR's meeting, I discussed with Kumach and Ogami. Not only reentrant mechanism, we should try to detect the trigger mechanism of ventricular fibrillation. Even though it is large animal study and all the paper published by Idecker, in the swine ventricle and canine ventricle study, more than 40% of VF mechanism, not VT, VF mechanism is non-reentrant mechanism. So we always try to trace the reentrant circuit in current technology, but please remember there's non-reentrant mechanism to treat VF. Okay. Any other question?
I have more questions.
No, okay, please.
If there's this posterior, anterior posterior septum.
He will try next week.
No. Anterior posterior septum, and if you put a line and this line one line and one line here, you should always encounter septal fascicle.
I prefer the Dr. Nogami's approach. So there is a there is 3 fingers and 3 fascicles,
there's network in
Yeah,
between.
yeah.
It may generate a reentrance,
Yeah, yeah,
micro reentrance circuit. It's just longitudinal. Very don't ablate in the over the mid to apical side.
Don't go over mid.
No.
Mid to only apical.
Yeah,
Long
apical side. Don't try to come up to the, and don't burn wherever there is. You should see the Purkinje. Okay. Actually, I think when we can try the randomized clinical trial after the reentrant VT ablation, if there is an inducible VF, we stop the case so far, but we can divide the group, additional denetworking versus no, just to finish the case.
There's a recent paper by by Curley et al. They adjuncted the Purkinje network. Yes,
Was the RCT?
no red cross.
No returns. And I think I talked too much, but the last talk, the Bordeaux group, they are doing the Purkinje D networking as pruning, and actually they ablate a lot. It's very, very extensive ablation, but I don't agree to disrupt all the Purkinje. They can reduce the BF inducibility and the IC shock, probably halfway they will. So I think the Nogami's approach, for me, it's very reasonable approach, but we need more. Okay. Final comment, Dr. Yu.
Could you show me the charisma slide?
Oh.
범이 티마 선생님께 한번 사진 찍어서 이거 보내드리고 감사의 인사를 드리도록
So can you please erase the fee?
It's very realistic. Is it? Okay, please turn off the recording. Okay, thank you very much. Have a nice weekend. 장 선생의 레파트죠?
네, 맞습니다.
콘서트 좀 잘 챙겨줘.
아, 네, 알겠습니다.
뭐 아침에 컨퍼런스 할 거네.
네, 알겠습니다.
오케이. 아, 수고하셨습니다.